Thank you for showing up here. We're going to be talking a little bit on something that we missed last class, but is going to be included in the following exam. It's about the pancreas. So liver and biliary tract and our system has been already discussed. Pancreas is very, very close to that. One piece of advice: read your anatomy of the pancreas. Know where it is located and exactly what blood supply goes to the pancreas. It's one of the most the organs that have most of the blood supply that you can imagine besides the stomach. If you talk about the spleen or the liver, they have one or two basic arteries, and they have one specific function for purpose in this matter. Here, pancreas, you're going to learn that it has two specific functions, but it's a little bit more than that can give either being normal your health, or if it's abnormal, there's some dysfunction, you have quite an impairment. So, like I said, it has a two dual function as an endocrine and exocrine type of gland. Think about, like I said, where it's located is in the epigastrium, going on the central part, and it's in the retroperitoneal area behind the stomach, the gastric organ. The thing important here is that attaches to other retroperitoneal structures, and this is something that I'm going to do a first pointer for you. Anytime that you happen to have a pancreatic type of pain, yes, you can have an abdominal pain, quite acute because of the nature of the organ and what the blood supply implies, or the condition that might be a gallstone or a tumor, something that's compressing that area, and even ischemia could be a big problem. Now, the other thing is that it's very close to certain ganglia and nerves of that celiac plexus. So pain is going to be irradiated to the back, referred to the back side. So back pain that is about that level of T12, L1, that's going to be the level of pancreas. That's where it's going to be located, that pain. Three parts are essential to understand the anatomy of the pancreas: the head, the body, and the tail. The other important factor is that the exocrine tissue, that the pancreas is about 98%. Endocrine is going to be the rest. So most of these cells are going to be giving those enzymes to the second part of the duodenum for the purpose of metabolic process of food, as proteins, starches, fat goes through there. Now, the pancreas has two specific conducts or pathways. One is going to go along with the biliary tract, is going to form that common bile duct into the pancreatic duct through the ampulla of Vater. There's one specific sphincter of Oddi, or Oddi, whatever you want to pronounce it, but it's Oddi. And there's another secondary tract that it goes from the pancreas directly to the duodenum, and that's a little bit above or superior and posterior to this ampulla Vater, and that's called the Santorini duct. So digestive enzymes that are produced by the pancreas are controlled by vagus nerve. So any stimuli or stimulus into the stomach by food, basically fat or protein, even I should say carbohydrates. So the three groups are going to be stimulating the pancreas to produce and secrete specific substances. Some of the most important ones, as you can read there, cholecystokinin, the secretin, peptidases, amylase, and lipase. All of these enzymes have a specific function to work with specific types of food. The endocrine cells are quite scattered within mainly the tail area. These are called islets of Langerhans. The islets of Langerhans are the ones that are going to be producing specific endocrine type of secretion that's going to be either insulin for the beta cells. Alpha cells will produce glucagon. Both are directly drained into the bloodstream, do not go into the small intestine. So things that you'll see in talking about this review of pancreas, you can go follow and read this overview. One of the things that are important, probably the third bullet, where it says that pancreatic juices are really pro-enzymes, so they're inactive substances within the pancreas, and until they reach a point where they have either that specific food as protein or carbohydrate or fat, that's where the enzymes are going to be activated because of that. Now there's some instances when if for some reason those enzymes are activated within the pancreas, they're going to destroy the pancreas and they're going to form something that is called pseudocysts. So this is important to recall it and be careful of this condition and knowledge of this, because many people might think that how does the pancreas then doesn't have like the stomach will have a lining that can hold a pH of 2. Well, the normal pH, you know, is 7.4, 7.3, but if you happen to have this situation of having this pancreas and having all those enzymes, is because they're pro-enzymes, they're inactive. But if a trauma happens, the situation of dysfunction within the pancreas, these pro-enzymes will start being activated, and they're going to digest, and they're going to destroy in some way the gland, and what's going to happen is the formation of pseudocysts. That's the term. Common causes: alcohol, any blockage because of bile stones, other known reasons, but typically they're trauma or after surgery, some drugs, metabolic diseases, and some infections. Mumps. Mumps have two specific things. One is specifically for the parotid gland that's going to get swollen because of the virus. But for adults, one thing is going to be very distinctive. They're going to have what is called a swelling of the testicles. So that situation is going to be a problem for certain amount of patients suffering of this because there might be infertile in time. The other situation is that pancreatitis also can be caused by mumps or related with this infection of mumps. Again, review this specific diagram as the anatomy goes. See how an acute pancreatitis with that activating of enzymes. The other important thing is that if you recall in anatomy, I said, because I taught you this, the third part of the duodenum into the fourth part of the duodenum, if you see it in this diagram, is even behind, posterior to the pancreas. So that part, or those portions of the duodenum are going to be retroperitoneal. It's not until they reach that ligament of Treats that it goes and changes to the following small intestine into the jejunum. So things that can happen, you have them there as what can cause an acute pancreatitis as trauma or surgery, drugs, virus, and what happens is the necrosis of those acids because the leakage of enzymes within the gland. Some bile stones, as you can see here, number 1, are obstructing, so anything that gives backflow is going to give some sort of inflammatory reaction within the gland. Alcohol is another big stimuli or a factor for this to happen. And typically what happens, there's some vessel wall necrosis with hemorrhage, and those enzymes go into the bloodstream. Some features and complications. You're going to have high white blood cell count. You're going to have elevation of these enzymes. You're going to have some other type of situations as fatty necrosis, some calcifications, and even hypocalcemia. If this drains into the abdominal cavity. It's not going to be the contaminated or septic type, so it's going to be a sterile type of peritonitis, but a situs is going to be there. The accumulation of fluid in the abdominal cavity is going to happen. You might end up having shock. The massive necrosis of formation of pseudocysts is common with this situation. The formation of abscess going into chronic pancreatitis. A situation that also can happen as a complication is the presence of diabetes. So if you follow this chart, or this flow chart, it's going to be easy for you to remember how from an acute pancreatitis, what happens. The sad thing and the important thing to realize is the fact of death in some of these patients might occur. A macro and a micro type of view, and hemorrhagic and swollen pancreas and some necrosis that are scattered through parenchyma of that pancreas. A pseudocyst, like I said, this is the pancreas as you can see it here. I think behind either is the liver, for what all I can say is I believe it is. So this is open, and this is the formation of pseudocyst within the pancreas. Once it's been liquefied by the enzymatic action of the digestion of those substances that are produced by the pancreas. So those are pseudocysts. Causes of chronic pancreatitis, alcohol is going to be the number one. Trauma can also be a big one, but not that often. Unknown is 20% of cases, but alcohol is the one that it's important as chronic. So again, as being an advocate of wellness and good habits, this is something you have to know besides tobacco smoking. So one of the things that is going to be as clinical features, one of onset, that it's not that acute, but it's insidious, and eventually it'll remain there. It's typically in the upper abdomen and radiates into the back. As I told you, the reason as being retroperitoneal and being very close to certain ganglia, to the celiac plexus. So malabsorption is going to be the first and most important clinical sign. So the term being steatorrhea. So steatorrhea means that you have a formation of feces that it's included with a lot of fat, and that's what you're going to have in your feces. Maybe in this chronic pancreatitis, the presence of calcifications within the organ might be a significant feature, and chances of a secondary diabetes to produce is going to be also present. Typically, what happens with a chronic situation versus an acute is that action that, for whatever reason, gets some swelling or some situation that once that stimuli or stimulus is removed or it's controlled, the organ can have some reversible changes and go back to normal. The chronic type is something that keeps going on, and what's going to happen with any organ is the presence of scar or fibrosis of that pancreas. When that fibrosis starts, atrophy of the gland, and eventually loss of all the functional units. Some intraductal stones or some parenchymal calcification, like I said, in the x-rays are going to be present, so this is the reason why you're going to have them. And in some situations, one of the important factors is that the area of the cells that are going to be the exocrine cells are affected. The endocrine, the islets of Langerhans, are going to be preserved. So sometimes, even though they're present, they can be reduced and they're going to be replaced by fibrous tissue. But this is the reason why diabetes is going to be a complication, a later complication of this. And if you follow this type of diagram or picture, slide, you see the stones, you see the formation of pseudocysts, the fibrosis that is present. Some nerve can be trapped there too, so you're going to have also to remember within your anatomy what is the innervation of the pancreas and what goes there, so nerve can be trapped and what type of condition that can follow because of this. There's a dilated canal of the pancreas with presence of some stones. The histology, just try to see or know that in the the chronic stages, fibrous tissue goes in. This is an F for fibrous tissue that is related, and surrounding those ducts. Here on the right side, you can see the ducts that are being surrounded by that fibrous tissue as replacing the normal tissue. Some cancers that can happen, 95% are going to be more of exocrine than endocrine. Everything is going to be derived from ducts, so glands or adeno is the name of what is going to happen. If they're solid, they're going to be much more frequent, and malignant is also going to be more frequent. So being endocrine is not as often. Islets of the acini is not going to be that common, same as being benign or cystic. Most of them, and this is the reason why most of these cancers are extremely fatal or in an advanced stage when they're first localized, is because they're functionally silent. They have hormonally active or normal, and they secrete neither hormones or enzymes. So this is the reason why they will be a problem. They're not going to be that showing off that much. It's the fourth major cause of cancer, fifth in women, 25 new cases. Smoking has been related also with adenocarcinoma of pancreas, increases ×3. In chronic pancreatitis increases the risk ×2. It's rare before 40. Incidence will increase with age, and like I said, prognosis is quite poor. Most of them die within the first, within 2 years, 3 years of the diagnosis, and sometimes they're so advanced and then never gave any type of symptoms, or the symptoms were thought probably as having heartburn, having some other type of situation, that eventually, by the time they get diagnosed, lifespan is going to be not more than 6 months, and that's what I've been knowledgeable of. One of the things that makes it hard, because the non-specific type of situations that might be considered probably even good as having weight loss or looking into that, loss of appetite, the thing is that there's pain upper quadrant or upper abdomen, and suggesting some sort of pancreas as the organ. Always try to think about it. And nausea is going to be a big one. Now the main part of the pancreas that suffers this type of cancer is over the head. Head of the pancreas is 60%. Anywhere could be 25%. About the body is 10%. The least is the tail. So to remember that the head is going to be the most associated with cancer. Think about these structures being obstructed, so bile goes up, changes within the pancreas are going to happen. There are several techniques to remove the whole pancreas or the head of the pancreas along with the duodenum, and that's very technically demanding surgeries, and not all of them will have a good prognosis because the chances of this already having metastases. So, like I said, non-specific and generalized can be, as clinical features go, jaundice, having icteric type of color in your skin, your sclera under the surface of the tongue. Those are the places where you're going to be able to see jaundice, and the thing is that there's obstruction and bile forms there. There's a situation as a sign called Courvoisier's sign, and Courvoisier's sign is done by palpation at the area of the gallbladder. And if you see where I'm touching, not necessarily at the mesogastrum or epigastrum, but really in the most medial side of the right hypochondrium, that's where you're going to have the bile or the gallbladder distended. Jaundice goes with itching, so that's another clinical factor to be aware of. Pain, when it's located in the tail of pancreas, it invades the celiac plexus. So again, know your anatomy, what structures are within that area. Having a spleen that has grown because of obstruction from that splenic vein is going to be also a problem. There's another sign which is called the Trousseau's syndrome, And this has to do with thrombophlebitis that is migratory. So you can have thrombophlebitis in different sites, and that's the Trousseau syndrome. There can be some metastases to lymph nodes, and depending on where those lymph nodes are, most likely either to the duodenum or near the liver, they're going to give some sort of signs or situations as obstruction for the gut. Some diagnosis that it's important to follow is with a CT scan or the ERCP, and having some cytology by aspiration to look into the lab and path and finally make a diagnosis. Like I said, prognosis typically is an incurable disease. Survival rate is typically less than 5% to 5 years. So 3 different ways of looking at this adenocarcinoma of the pancreas. One being a well-differentiated type of pattern, moderately and a poorly differentiated type. So the less differentiated is, the more aggressive it'll be. But again, some tumors are rare, like the endocrine cells of pancreas, the insulinoma, gastrinoma, glucagonoma, somastinoma, and biipoma. Those are just names of the cells that are included having some changes as tumors, which are rare. Probably insulinoma, thinking about the beta cell tumor, will go again reversed by infusion of glucose, hypoglycemia, syncope, and profuse sweating. Profuse sweating are the typical signs what you're going to have with this. The gastrinoma goes with one specific situation. This is from all the cells that are pluripotent, and there's one specific syndrome that is the Solinger-Ellison syndrome, and those are multiple gastric ulcer, and these are unresponsive to medical therapy. So again, you have peptic ulcer disease, you think that probably Rolaids, Tums will make it better, or some of the what's the name of, thinking of, the medication that will control secretion of gastric fluid acid. So it's any of those medications that doesn't go better. You have to think if they have pain also in that area of the epigastrium. Think about cancer of pancreas. Think about the Solinger-Ellison type of syndrome. And most of these are considered to be malignant from an EN1, the multiple endocrine neoplasias. In diabetes, I think 2 main conditions here to understand. The beta cells are the ones that produce insulin, alpha cells, glucagon. There's one delta cells, which are the less of them, that produce somatostatin or pancreatic polypeptide. But the thing is, beta cells, insulin, alpha cells, glucagon. The primary type of diabetes is very specific as having a type 1 and type 2. The difference between them is type 1 is insulin dependent. It's considered to be of some genetic factor, some conditions that either by mutation of some sort, but this is the type that was also considered to be juvenile because you get this type 1 typically around age 8, 9, 10 or so, and that's when you become insulin dependent. Could be at later age 2, but typically it's not the common reason. And 5–10% will have a type 1. Type 2 is a non-insulin dependent. This is the type of the older people get that has to do more with lifestyle, with obesity, with being overweight. So think about all those things that you always hear as why you're going to get a type 2 diabetes and how to control it, typically with diet, exercise, and you have to have some medication you can take it. The secondary type for diabetes, not necessarily as type 2, 1 or 2, but the secondary is related with any of these conditions. We went already with pancreatic diseases as acute or chronic. So again, type 1, type 2, you have these tables, go over them slowly, understand what we're trying to do with experimenting with some differences between gender or between lifestyles, age, family history. And like I said, type 1 will have some sort of genetic situation that probably is considered that there's some antibodies being formed to attack those beta cells in the pancreas, or the islets of Langerhans, and those are going directly and attacking those islets, and eventually insulin is not being formed, so you need insulin to live. So that's why it's called insulin dependent. So histology has to do loss of beta cells. Treatment, what it says there, insulin. And type 2, you can have insulin if you have some resistance to insulin naturally, so you can add a little bit more. Some diet, exercise, and oral hypoglycemics is important. So the pathogenesis of this hyperglycemia, go over it again. As you can understand, insufficiency of the islet cells, the decreased demand for insulin, or peripheral tissue resistance. Those are the reasons why you're going to have diabetes. When you have increased glycogenolysis, why you're going to have hyperglycemia, and you're going to get the triad of eating more. You're going to start having loss of glucose through the urine. Because of this, you have more frequency or more volume. Basically, it's more frequency along with a little bit of volume. And because of that, you're going to have some sort of dehydration, so you're going to have more thirst. So you're thirsty, you're eating more, and you're peeing more. So you go more to void your bladder. So because of this, once you have the volume depletion, so you go into some dehydration, you're going to have more glycosuria, you have a hyperosmolality, then you fall in what is called a diabetic coma. Same thing with diabetes, that increased lipolysis. So you're going to have two situations, one with the carbohydrates and one with the lipids. So follow each one of those two. But the formation of ketoacidosis, how are you going to know one person has diabetes and having ketoacidosis? Typically they smell like apples. So apple cider, apple something, fruity type of, and apple has been designated as the smell or the odor that the scent that they are forming because of the ketones and the ketone body formation. So ketoacidosis gives that specific smell as apples. And so when it goes in both ways, not one or the other, increase glycogenolysis, increase lipolysis, so lipolysis. So any of those two are going to be happening finally to end up with a diabetic coma. So it's very important to have control of these situations. Just an image of a microscope looking at the islets of Langerhans, the fibrous tissue, all this stuff that you see here in the pinky less color. And the complications, you know some of them, cardiovascular arteriosclerosis and gangrene of extremity or toes, fingers are going to be the first expression of this. Also some sclerosis of the arteries, the smaller ones. In kidneys, you're going to have the glomerulosclerosis. Remember I said sclerosis is the hardening of the structure, in this matter, the glomeruli, and the presence of some infections as pyelonephritis goes. Retinopathy is very typical as eye complication with diabetes, and some neuropathy that you always are listening in ads as taking medication as neuropathic analgesia for this type of peripheral neuropathy. So we'll stop here for pancreas, and we'll move on for the following chapter. Thank you.